the next speaker will be Dr. Ranj Khaffaf. Ranj is a Sulaimani graduate, you would like to know, and he's a consultant in anesthesia at Prince Charles Hospital, UK. He's going to go and talk about ALS algorithm.
Thank you very much. Do I need to?
No, it's not. This is only for the camera.
This presentation.
استاذ بريزنتر رانج تحتاجه؟
لا شكرا والله
ما اعطيك ما خليتني ما اعطيك الصوت.
شكرا لك. شكرا جزيلا. يعني تامباش نيورو تامباش هش تاس نيورو يا يعني ساعة زمانية فيش نيورو ها يو تاني ما شكرا بقولن دن توزطانية حلامتي كي بسيطة بها أيتر بالنسبة لي I'm just going to talk in English. I know all of you speak Kurdish, okay, but for the purpose of the course, we're just going to conduct the course in English. As Moayad nicely introduced me, I'm one of the consultants who works along with Moayad. We work in the same hospital. I'm pretty much quite involved with resuscitation, and today we're going to cover about ALS algorithm. So throughout the day, you have seen a lot of information about how we recognize the sick patients, how we do resuscitation. The main ideas, these lectures, as we has always explained, they are simple. The priority for you is to stabilize the patient. And after that, it's basically, we will do the aftercare of the patient, that we, which we will continue to discuss that in further workshop and teaching that we do. In terms of the ALS algorithms, we concentrate on how we basically stabilize the patients. We're not talking about a sick patient who's on the ward, you're trying to do some specialist training in there. They are unconscious patients. They are about to die. And from your priority of view is basically when to be, what to do, what is the right thing to do, because at that time is a very, very chaotic situation and there is a lot of people around there. And that's why having an algorithms for you is very important. And we teach this course to everyone, including the nurses, the junior doctors, even the consultant. This is a mandatory course from the top. Even we have consultants attending these courses, they should have doing it. It's expired every 4 years, and during that 4 years, you need to maintain your skills all the time. So it's not just today you go there and you know everything. It's something for you to develop further. The aim of this lecture is obviously to understand the ALS algorithm, understand the importance of high-quality chest compression. State the treatment of shockable and non-shockable rhythm, and know when you give drugs during the cardiac arrest. Treat the potential reversible causes of cardiac arrest and understand the role within the resuscitation team. So in every team, we have a team leader. So it doesn't matter you are the most senior person or the less senior person. Someone has to lead the team. As long as you know what you're doing, it doesn't matter. It's basically a team leader. You step back, you look at what others are doing, and each one's feeding back information to you. Right. This is a quite busy slide for you to look. But obviously, you can see you get an unresponsive patient and you start the CPR. And someone's doing a chest compression. At that time, You might be by yourself and there is no one else. And you basically identify the patient as unconscious. You assess for 10 seconds. And once you do that, once you realize the patient is unconscious, you start doing chest compression, so you don't wait. The main important thing is to minimize interruptions, because by doing chest compression, you supply blood to the brain, and that's the most critical things. Brain will die within 3 minutes, okay? And if you don't do that constantly, it doesn't matter you're oxygenating the patient. If you're bagging the patient, that's not going to keep him alive. It's actually, if blood doesn't go to the brain, even though if you give him oxygen, it's not going to keep him alive. So it's that's why the first things we need to focus on is to do the chest compression. And that's what is the UK Resuscitation Council has been emphasizing, is to doing effective chest compression. When you put you basically attach the monitor. At that stage, you step back, and it should take you less than 5 seconds. You look at the monitor. I know here in Sulaimania we don't have a proper chest pad, the gel chest pad that we do. In the UK, it's a standard. In every resuscitation trolley in the UK, you get a chest pad, you apply it. It's the apex of the, once to the left side, the apex of the heart, and to the mid-sternum, you apply it. So once you put it, it gives you a rhythm check. So you step back, and you say, everyone stop, step back, and you check the rhythm. So it's either shockable and non-shockable. So with the shockable rhythm, it has a slightly different pathway. With the non-shockable one, it has a different pathway. So you can see non-shockable one, it could be either PA or asystole, and then you continue doing CPR without any interruptions. So you jump back on the chest and you start doing CPR. And then you give adrenaline straight away at that time. If it's in the shockable side, obviously it's either VT or VF, and the waves are very clear. So you check the pulse of the patient, central pulse, usually they are compromised. So these patients who are resting, they are compromised patients. They are not the sickest one. You don't check the rest. You check either there or female. And then if it's actually VF or VT, you can see it easily on the cardioversion monitor. And you straight away don't delay it. You go back on the chest again until you start charging, you're giving the first shock. And then you go back, continue doing CPR for 2 minutes, and then reassess it, so you don't disconnect. So that's the main thing. So I will elaborate more on this. So the patient, when you do see a patient the first thing you do before you do anything else is check if they are alive. And I remember I was a house officer in Sulaimania CCU. I was very junior. It was my first week, and there was a patient connected to the monitor. And suddenly we were in the monitor room, and actually the first things we noticed the screen went flat. And one of my colleagues, he just went in. He was much senior than me, and I could see him getting ready to. Basically, he said to himself to want to give him a thumb, and I just told him, wait, he's still alive. He was asleep, and his ECG leads come off. You understand what I mean? It's so easy to do that, and we've been junior and we know that. But the first things you do is actually lift the chin and check the pulse for 10 seconds, and that's what we recommend. Okay? If they have a pulse, you put your finger there. You could hear if they are breathing. If you touch someone and you lift their chin, they don't like it. They are awake, unless their GCS is very low, compromised. They don't respond. Then you check for the pulse. This is a very important step. We have a very developed system in the West, which we call resuscitation team. So we have a common number we contact. So everyone has got a radio bleep similar to that machine. You attach it to your wristband. So there's an on-call system in the hospital. It's made of consultants, anaesthetists, junior doctors, nurses, and they are basically carrying these bleep. When there's someone who's become unresponsive, there is a red button. You press it by the side of the patient. That set the alarm, or you just shout for help. Help, help, I've got an unresponsive patient. When someone's there, you call straight away. So you assess the patient is not responsive. you go and make a phone call straight away and say, can I have some help, please? Or you press the buzzer if you have that system. If you don't have anyone, just go out and get a phone and press 222. In the UK, it's a 222 number. In any other European country, it could be a different number, but that's a common number that you know. So if you decided to come and work anywhere abroad, you get familiar with this. This is a common thing. So you need to know that number. So you call the resuscitation team, and then you immediately come back on the patient and start doing CPR. The main thing, as I said, is to minimize interruption and doing chest compression. You'll do 30 to 2. So because you don't have an airway there, so you'll do 30 chest compressions. And then you attach the monitor pads and all sorts of things that you do, as you can see. And usually put our hands on the lower third of the sternum. So we don't actually go and measure things. We know that you feel the Xiphi sternum. You put your hands, thumb, on the lower one third of the sternum. And that should be sufficient. We're not going to be about being accurate and how many centimeters, but that's what we will do. It should be in the center of the chest, 5 to 6 centimeter depth, 2 per second. So we lose the count. I usually say, in my head, I count 1 and 2 and 3 and 4 and 5, so that you can give a rate about 100 to 120. High quality compression, and then we can practice that later on in the workshop sessions that we do. It's continuous chest compressions. If you've got someone experienced with airway, if they manage to establish an airway, then you don't do 32, you'll do continuous chest compression. And then it's very often, I don't know how many of you have done chest compression, but sometimes we carry on for about 45 minutes. And after doing chest compression for 4 or 5 minutes, you feel yourself very tired. And one of the things that happens in these situations is your quality of chest compression is not becoming effective. It's just becoming less effective. And that's why we will say 5 to 6 centimeters. So in one of the mannequins that we have, it actually does tell you if you are doing a good chest compression or not. In these situations, and avoidable, sometimes we break people's ribs. It does happen, especially if you have an old, crumbly person, someone who might already has been a trauma. That's not going to kill him. Rib fracture is going to be fixed by itself. So you can see we have a start doing CPR. Then we pause when you put the the chest pads to assess the rhythm, whether it's a shockable and non-shockable. That's the main things you need to know. You're not going to worry about, is it pulsed VT or pulseless VT, or is it SVT, or is it atrial arrhythmia? We're not talking about this. We're talking about two main things. Is it unconscious patient's variance thing? Is it a shockable or is it non-shockable? That's the main things you do. And then, if it's a shockable, everyone knows this one. Very bizarre, irregular waveform, not recognizing a very obvious QRS in here, random frequency and amplitude, uncoordinated electrical activity, and it could be coarse or could be fine, so it could be either of this. Sometimes you need to make sure, that's why you ask the persons to step away from the patients, because it could be an artifact. This one is VT, you can see. It's monochromatic VT, broad complex, rapid rate, constant QRS morphology. Okay? And sometimes you need, if it's a polymorphic, could be a dorsal 2-point. So once you do that, you straight away think of shocking this patient. But what you will do, when you're trying to prepare for the cardioversion machine, you're not going to step back, oh yeah, I've got excited, I've got a shockable pulse. Step back, guys. No, you back on the chest and start compressing. While you're preparing, you will allocate someone to do that for you. You're not going to be the one who's going to deliver the shock. There will be other people's coming around. And essentially, what do? You will allocate that person and will say, can you be in charge of the cardioversions for me? And you'll charge the defibrillator. And you'll continue doing CPR, but you'll tell the persons who's doing the airway to step back. So you charge the defibrillator and you deliver the shock. And then you immediately go back on the chest. You minimize interruption in the chest compression, and you can see this message come across on and on again. So, defibrillator, I'm not familiar, it's been a long time, it's been more than 18 years since I left my city. I don't know what's happening in the hospital, but I know nowadays in every hospital they might have different defibrillator. As a junior doctor, when you go to any hospital, make yourself familiar with the machines in there. Just go and see what is it, what setting it has. In the old times, we used to have two different types, monophasic and biphasic. It's just the electricity engineering is different. The type of energy is delivering the same force, but it's just the physics about it is slightly different. Nowadays, most places, they have biphasic machines, and you deliver 150 joule, and make sure you don't delay that. Okay, if it's a shockable one, you just deliver the shock. We will talk about the energy level when we do the practice. So if it's a VT or pulseless, VF or pulseless VT persist, you deliver the second shock. So you continue for 2 minutes, and on the second subsequent shock, you can see basically the energy level, and then we give adrenaline in the third shock. We don't give adrenaline at the beginning here. So we start doing chest compression. Yeah, we do the cardioversion, and then we go back on the chest, and then we check the rhythm. It's still VF and VT. We go back and we deliver another shock. On the third shock, before that, we will give adrenaline, IV, 1 milligram and 1 in 10,000. We have in our resuscitation trolleys pre-drawn syringes of adrenaline. So the strength is there. You're not going to think about it. We know it's 1 milligram and is diluted to 10 mils, which makes it 1 in 10,000. And you give that and you flush it with a big syringe of saline or flush, so that it will go, because these patients are compromised, so their circulation is poor. So you need to flush it with a lot of fluid, and then you continue doing CPR, and then if they don't, then we can give adrenaline after the third shock. So we can consider giving other drugs, but the main one here is we don't give adrenaline at the beginning, we give it in the third shock here. Right, so again, minimize interruptions in the chest compression. We move into the non-shockable side. You can see this is a flat line, and as I told you, it can be easily, someone's chest monitor is not connected, it can be easily look like that. So it's absent ventricular activity, absent electrical activity. There might be some electrical, my P waves might persist. It rarely is a straight line. You will never see a straight line. Okay? It's usually like this. Adrenaline, you give straight away when you see this one, and you go back on the chest compression. Sometimes you'll see this rhythm, okay? And you would say, okay, actually the patient has a rhythm, and then you feel the pulse, and you can't feel anything. And you feel the femur, and sometimes you doubt yourself, and you ask someone else, can you check on the other side, please? It's a very chaotic situation, as I've said. So you will feel the pulse. If there isn't anything in there, and there is electrical activity, it means it's a pulseless electrical activity. It means that the heart is contracting, but it's actually not pumping. So it's actually, the heart is moving, but it's not pumping. So that means there is some electrical activity in the heart, but there is no mechanical activity. And in these situations, we call it pulseless electrical activity. So in this situation, we still treat it as a non-shockable side of the rhythm. So, again, ensure high quality chest compression, minimize interruption, the same principle. Okay? We use a lot capnography. I don't know if you're aware about what's capnography. Have you used capnography here? you know when do you use capnography? What is capnography?
Capnography is you measure the CO2 in breathing.
Okay.
But
And-
we don't have.
And why do you think CO2, why do we measure CO2?
It's an indicator of metabolic activity.
Of
Metabolic
pulmonary circulation. So there is a circulation in the lungs, meaning there is gas exchange. So you're basically producing CO2 back through your lung. And that's why. In the military, they use a lot of this. And it's one of the requirements to do. It's quite advisable. In the army, they connect them straight away, capnography there, because they know if their CO2 is above 2, means there is better chance of them, these patients, they recover from cardiac arrest. And then continued chest compression. Vascular access is important because we need to give adrenaline. If we couldn't get a vascular access, we can give intraosseous access. So that we will discuss that. We'll show you how we do intraosseous access in the course here. And you can see it's very easy and simple and is available in every department. In maternity, in A&E, in anesthetic department, even some critical care wards, ICU and CCU. So we do train people to use intraosseous. Again, going for capnography, it's give you a lot of information about if your CPR is effective, chest compression is effective. It's give you confirmation if your ET tube or airway is in the right place. If the ET tube is not in the lung, is not in the trachea, it's in the esophagus, you can't get capnography. Okay, so that's one of the things we use heavily in anesthetics. Okay? And also, it will help us about the progression of CPR. So if someone's we've been doing CPR for about 30 minutes, and end-tidal capnography is still going down. It used to be 3, now it's 1.5 and 1. I know the likelihood of this person survive is becoming less and less. So it does give you an indication. Right, this is very important. When we do chest compressions, we have a lot of time. So it's 2 minutes every time. So when you do, we need to think about the 4 H's and the 4 T's. The 4 H's, these are the reversible causes. And we go through them through the day when we do the workshops. So you need to remember them. So 4 H's, we can see with the diagram, you can remember it yourself. Hypoxia, hyperkalemia, or hypokalemia. So either of them's electrolyte imbalance. Hypothermia, someone who's been drowned in the river, and they are hypothermic. They come after longer hours, they become hypothermic. So you need to think they are really cold and they don't return spontaneous circulation. Hypothermia could be one of the reasons. And then hypovolemia, someone's bled and they are not returning spontaneous because their vascular system is completely empty. No matter you do chest compression, if you don't fill that vascular system with blood again, then they won't recover. There is a term, we call it traumatic cardiac arrest. There's still, if the heart is beating and there is electrical activity, but there is no blood in their system, unless we give them blood or fluid, they are not going to have cardiac output. So you need to think about hypovolemia, someone who's bled from stomach, or bled from a trauma they had, or internal bleeding. Okay. Then the 4 T's, and you need to remember that. The tamponade, the tension pneumothorax, thrombosis. So thrombosis is a general term, so someone's could be a pulmonary embolism, or it could be cardiac, acute coronary syndrome. So it could be any sort of thrombus. And then toxins. So someone's been overdosed, they had taken some drugs, or someone and inadvertently on the ward has given some wrong medication and they go to a cardiac arrest. And sometimes we do actively say, have you checked the drug card of this patient by the side of the patient? So once we do cardiac resuscitation, someone's taking the care of the airway. So he's going to stay on the top end. 2 guys on each sides of the patients, they do chest compression alternating between each other. And that you always asking them, are you happy with the airway? Can you ventilate? So we will talk about this through the workshop, and Dr. Sadeek is going to basically teach you what are the basic airway maneuvers and what we do. And sometimes even in anesthetics, I always stick to basic airways. When I can't ventilate the patient, when I lose my airway, I just go back to the basic. I put a Goodell airway in face mask and I start bagging them because that's the only way I know what's going on. Okay. And then hypovolemia, as I said, control hemorrhage wherever is the source, and either give intravenous fluid and blood, preferably if you know the cause of arrest is because of bleeding. You don't delay blood, because that's the only thing. So if you give too much fluid, you're diluting them. And then hyper and hypokalemia. This is available in theatres, in the lab, in critical care unit. You can just take a venous sample quickly from the femur, or anywhere that you can get access when you put the Ventolin in. You send the sample, and it will give you an indications if they are electrolyte imbalance. I had a patient I intubated. He was very sick in critical care. I put the tube in and I couldn't get end-tidal CO2. And I was looking, he didn't have any cardiac output. And when I sent the blood gas, his potassium was 7.5. In a matter of seconds, we have given calcium gluconate and he retains coronary circulations. We basically knew the reversible causes. It does happen. You need to look at the causes. Okay? And hypothermia, as I explained. So there's a lot of things we can warm the patient. And probably in your hand packs that we have given you, we have put you all this information in there. The 4 T's, the tension pneumothorax. You need to know the clinical signs of tension pneumothorax. So these patients, you can see the chest is not rising, there's history of trauma, they've been crushed by something, they had a fall, and all these sorts. You need to make sure that this is something that doesn't go out of your mind. And then tamponade, someone who had a recent cardiac surgery, cardiac bypass, it could be quite common, or they've been involved in motorcycle accident or car accidents because the steering can compress your chest. You get basically tamponade. So you need to think about in the context when you go, is that could be this possible? There was any history of the trauma at the time when you do the resuscitation at the time? Then thrombosis, PE, we do see that very often. And then toxins. So secure the airway. We will talk about this in details. We, as a ALS resuscitation council, we do recommend simple airway techniques, supraglottic device. Yeah. Do not attempt intubation unless you are competent. So we leave that for the expert people. When I'm anesthetist, I go there, I intubate. I don't have any problems, but it can be quite tricky. These patients, they might have vomited, they might have aspirated. It's actually, the view is not great. It is difficult to intubate someone on a bed when there's so much, the height of the table is not right, so it's not something for you to, the priority is not there. The priority is to use basic airway technique or best supraglottic device if you are competent enough. And we will do practice that today. Consider ultrasound imaging, mechanical chest compressions. We call it Lucas machine. We don't have it here. It's a machine, you put it on the chest and it does do the compressions. And they usually happens in the fields. So there's field trauma. So the paramedics, they usually have this machine in the back of their ambulance. When they transfer the patients from the field to the hospital or from a distant place, they put them on a Lucas machine. And sometimes even the patients, they are just about to talk because such a good and effective chest compression does deliver. Ultrasound, it's becoming more popular nowadays to use ultrasound to give you information if there is a tamponade or there is a pneumothorax. So, coming back again, assess the rhythm, then assess if there is a spontaneous circulation. Immediate post-cardiac arrest treatments, you need to go back to our ABCD approach, the one that Dr. Aziz has mentioned, and we need to reassess the patient all over again. So once the patient is back to stable, then you need to look at how we do everything else again. Okay? So this is the team that we have. So when you we might have about 15 people at the time. So generally, you can see this is this is how there's the team leader. You can see she's that lady there, stepping back, talking to the team. They're looking at her, giving information. She's having eye contact, and someone's doing the airway and listening to the chest. Someone's giving drugs, and someone's responsible for the cardioversions. He's on the side. He's making sure. So it's teamwork. And when you have the patient's return spontaneous circulations, it's an achievement. And that's it. Thank you. I'm sorry it took a bit longer. It's quite important.
Dr. Ranj, I have a question. This a piece of the green things on the chest of the patient, what is it? I frequently seen in their videos, YouTubes. Now, go back, please. Yes, this one in the left heel of the hand of this guy.
Under the compression.
I really don't know.
This is a device. Include three lights. Red, green, and yellow. That assess the depth, the rate, and the effectiveness of the cardiac arrest, of the cardiac compression.
Okay.
This is a new device. It was inventing through 2018, but it's not existing here, just in Europe and UK.
Thank you.
Yeah.
Thank you.
Okay.
Correct. Can I ask you something? I'm Dr. Saad Nabistani. I'm a sociologist.
Yes.
Asking in some days, they use the other positive inotropic effect on the heart before the third shock, before adrenaline.
Yeah.
Like aminophylline, ephedrine, before using pure alpha receptor. Is this the case till now?
No.
No.
No. We're talking about pure someone who's lost their cardiac output. But not someone who's a bit hypertensive and they are still having circulation. It means these people's cardiac is completely compromised.
I mean, if there is no capnograph, not available everywhere.
Yeah.
Well, you have to
I will do
ensure-
chest compression.
You have to ensure there is no ventilation perfusion mismatch,
Yes.
as you know.
Yes. So in these situations, even in theatre, sometimes I do get on the table, I anesthetize the patients, heart rate goes to about 25, I can't feel any pulse. I start doing CPR on the table. Even though I am in control, they are intubated, I start doing chest compression because there is no circulation. The basic thing is do chest compression. By the time you give atropine, that's not going to reach their system. So you need to do the chest compressions to accelerate the circulation. So the chest compression is the answer. Okay.
In our practice, usually adrenaline is missing. So in our practice
Yeah.
in Iraq, sometimes adrenaline is missing. There's no adrenaline. So is there any role for noradrenaline to use?
No.
Okay, so
Noradrenaline is a vasoconstrictor. Adrenaline is alpha and beta agonist. So it has both inotropic and. So we do use it in critical care, but it's mainly to improve peripheral vascular resistance and basically improve the blood pressure. Is not have an effect in terms of, doesn't have alpha and beta characteristics together.
Would improve the current circulation
Section.
with the adrenaline more than with the noradrenaline?
what if we don't have it? What to do?
Noradrenaline.
Adrenaline.
We should have it.
Yeah, we don't have it in ER.
Dr. Sadeek, we don't have adrenaline?
Yeah.
Well, this bolus, okay? Well, that of the anaphylaxis, it is 1 to 1,000, 0.5 milligram antilateral mid-size, and it is life-saving.
It is.
These two items should be available. There is no any excuse for shortage of adrenaline in the emergency crash cart.
Yeah. If you say there is no ephedrine,
Yes.
I would believe that. But adrenaline it's a life-saving drug. It's like people they have anaphylaxis, people they have allergy, urticaria. Do you know it should be available? I mean, people they carry the pen with them with adrenaline. Do you
We only
understand?
have practicing medicine for the last 30 years, but I didn't face any shortage of adrenaline anywhere. Maybe Daesh took off adrenaline with them.
Sorry.
Maybe.
Thank you very much. It was really very well explained. But I have many questions that I have gathered through practice in my...
When we do the practice, I will go through the algorithm and the chest compression with you myself. So if you have a lot of questions, we can always
Just
have...
one essential point, 3 successive shocks when giving shockable cases. Is it advisable to do so?
Yes. That's what is the ALS.
And what's the cut point for stopping the resuscitation?
Ah,
You know?
so this has become this is a good question. From my point of view,
I have another question. It's
Yeah.
just related to that
Yeah.
as well. This will be the last one, okay? I know, but this is related to it.
Yeah.
Okay, in many cases we have ICD, pacemakers, you know, these times they are affecting your decision. How can we decide?
So
Thank you.
yeah, so you need to realize it's not your sole decision to stop the resuscitation. When it comes to stopping resuscitation, it's a multidisciplinary team discussions. So sometimes there is you need to do a lot of background information. When you start doing resuscitation and the patient is not responding, you'll ask someone to go and have a look at the notes, see the background of the information of the patient, what's his comorbidities, what is actually the precondition of the patients when he arrested, okay? And also, what is the likely cause of his cardiac arrest? Secondly, depending on the age of the patient, sometimes they are comorbid patient, they are elderly, they are frail, they're coming a terminal event in their lives. So sometimes you have to be realistic. When you do resuscitation, it doesn't mean it's just the resuscitation of this patient. If this patient survived, would you be able to go back to his baseline livelihood that he was able to? What's the point of actually resuscitating someone who is going to be a cabbage on a bed all his life? Do you understand what I mean? When we make these decisions, we do on the basis of exactly how likely it is and what's the cause. Sometimes, if the patients return spontaneous circulations, we will stabilize them, we put them into critical care unit, and there will be further discussion happen by more senior people as a multidisciplinary. They will decide whether they can continue supporting this patient in critical care. But at the time, it can be difficult unless having more information and more senior people can be involved in making that decision. So you'll ask for help, and also you also involve the family sometimes with this.
But the issue is that we are working in the outside units. We are just ourselves, you know?
Okay.
We are the only body that decides is it terminated or not.
So what we can do, this is a good topic. We can actually discuss in the group meetings when you're there.
When join us now, we'll explain for you.
Yeah. So
Sorry. After successful resuscitation, can we consider sodium nitroprusside to reduce the afterload?
Sodium nitroprusside is it's basically for people with severe critical hypertension. Their blood pressure is very high. I mean, I haven't used it. In my clinical experience, I've been anaesthetist for quite a long time. I haven't really used it. In these situations, we don't. If we do ever use these medications, it will be post-resuscitation in critical care. Yeah.
Reduce afterload.
Yes. Okay.
Milrinone is more popular than sodium nitroprusside.
Yeah.
Because enhance myocardial contractility and decrease afterload. Yes.
We don't use it at the time, but post-resuscitation in critical care, depending on the right atrial pressure.
I never use it myself, but
Yeah.
I wrote about it.
It's becoming a bit out of fashion, drugs, and also not many people are experienced. But as you said, milrinone can be used, but that's more a cardiac drug. Sorry, I'm taking. Yes, sorry. What we will do is, just because we are running on a strict schedule of times and we still have a lot of stations to go through, we usually run this course on a 2 days course, and it's a